This is Christopher Graffio from Mayo Clinic, Rochester, presenting a brief supplemental lecture highlighting a key aspect of the rationale and data supporting our chapters on radiosurgery for intracranial vascular malformations in the 8th edition of Humans and Wind Neurological Surgery. The specific topic of my talk will be volume stage stereotactic radiosurgery for intracranial arteriovenous malformations, progression from theory to practice. It's my privilege today to present this data on behalf of myself and my mentor and our senior author, Dr. Bruce Pollock, as well as a representative of the Departments of Neurological Surgery and Radiation Oncology here at Mayo Clinic, Rochester. The presenters have no disclosures with regard to this presentation. AVM radiosurgery is a commonly performed procedure for patients with small to medium-sized intracranial AVMs, which causes endothelial damage, proliferation of intimal myofibroblasts, collagen production, cellular degeneration, and hyaline transformation, ultimately resulting in progressive closure of blood vessels. Conceptually, AVM radiosurgery pivots on three first principles: obliterating the lesion while avoiding radiation injury, and doing so prior to AVM hemorrhage. For more than 20 years, clinical studies of AVM radiosurgery have demonstrated that obliteration rates are highly related to dose. However, increased radiation dose is also clearly associated with increased risk of adverse radiation events. These treatment toxicities may have temporary or permanent consequences, which include a spectrum of findings ranging from transient, asymptomatic T2 imaging changes to frank radiation necrosis, which may be associated with radiographic enhancement and edema, as well as clinical symptoms. In tandem, landmark efforts to identify patients at increased risk of treatment toxicity have identified the 12 gray volume, or region of healthy adjacent brain exposed to a dose of at least 12 gray, as the most reliable predictor of T2 change and therefore radiation necrosis after radiosurgery for AVMs. Other early publications, such as this study of LINAC radiosurgery for AVMs, provide further evidence demonstrating that higher doses combined with larger treatment volumes is a formula for complications, with more than 22% of those AVMs receiving at least 16 gray to a treatment volume of 14 centimeters cubed, developing symptomatic radiation necrosis requiring resection. This pattern of injury was confirmed by our own institutional series, in which 1 in 3 AVM patients with a treatment volume over 14 centimeters cubed had permanent treatment toxicity. Taken together, these findings constitute a careful balancing act between dose and risk that defines the core challenge of AVM radiosurgery, particularly among larger lesions. In order to explore the specific issues pertinent to the treatment of large AVMs, we can consider this example case in which an 8-year-old boy presented with progressive right hemiparesis and was ultimately discovered to harbor a large, eloquently located AVM with deep venous drainage, a Spetzler-Martin grade 5 lesion. The history of radiotherapy for large intracranial AVMs can be summarized in 4 major movements: conventional fractionated radiotherapy, combined approaches involving embolization and radiosurgery, and either time or volume-based staging techniques. Although reported, traditional fractionation represents a marginal early contribution to radiation as a treatment for intracranial AVMs, with only one index publication demonstrating limited efficacy. Combined approaches reporting fractionation together with embolization showed modest improvements in obliteration rates, particularly among patients in the 7 gray fraction group, although these same individuals also experienced a high rate of radiation-associated toxicity, with T2 changes noted in 86%. By contrast, although studies of combined approaches involving embolization and radiosurgery have reported relatively robust obliteration rates with lower risk of treatment morbidity, AVM recanalization rates are considerable, impacting 12% at 1 year in a large early study of this treatment strategy. In this example case, planned using the Kula system, the top pair of images show an AVM that was initially treated with combined glue embolization and stereotactic radiosurgery. Unfortunately, as the bottom images demonstrate, the patient experienced an out-of-field recanalization of a previously embolized area of AVM at the superior margin of the lesion, ultimately requiring a repeat radiosurgery treatment. Here we see another example case in which a combined treatment with onyx and radiosurgery was planned, but an unintentional embolization of a left MCA branch resulted in hemiparesis and aphasia. With these treatment considerations in mind, a relatively recent propensity score-matched analysis attempted to address the question of whether pre-radiosurgery embolization contributes substantially to outcomes. Although the cohort was perhaps confounded by differences in nidus angioarchitecture, the qualified conclusion was that radiosurgery alone may provide better obliteration rates, while also sparing patients the potential morbidity of embolization. Within the contemporary paradigm of stereotactic radiosurgery for treatment of AVMs, two principal strategies have been attempted to mitigate the risks associated with treating larger lesions at meaningful doses. The first such strategy, known as temporal staging, involves a single treatment plan that is divided into multiple sessions, during each of which a partial dose of radiation is administered. Although this approach eventually achieves reasonable obliteration rates and dramatically decreases the incidence of adverse radiation events, the inherent time-based delay in delivering the complete treatment leaves patients exposed to risk of rupture for a prolonged period prior to obliteration. Having recognized the limitations of dose fractionation and combined strategies involving embolization and radiosurgery, several centers developed a second strategy in which volume staging techniques are used to treat large AVMs. Here we see an example case in which the medial component of a large AVM was treated first, with the full radiosurgery dose delivered to a volume of 9.9 cc's. The patient was then brought back for a second stage treatment, during which the same dose was also delivered to a separate lateral volume of 8.3 cc's. Using this volume staging technique, we are theoretically able to deliver a higher dose of radiation to the entire AVM volume while simultaneously reducing the radiation exposure to the adjacent brain. We reported our initial institutional experience with 10 patients treated using this strategy by retrospectively analyzing the 12 gray volumes associated with each treatment plan. Overall, we noted that the 12 gray volume was markedly decreased among patients who were treated with volume stage techniques. Perhaps more importantly, we also noted that when the same comparison was performed with the volume of the AVM itself removed from the calculation, the differences in non-lesional 12 gray volumes were dramatically improved by the volume staging approach. Our cumulative experience now includes more than 45 patients with large AVMs treated using volume staging from 1997 to 2018. These patients were a median 30 years old at time of treatment and generally represented higher grade lesions with a median radiosurgery-based AVM score of 3.14, requiring 2 to 3 stages in most cases to treat a median volume of 24.5 centimeters cubed at a typical margin dose of 15 to 16 gray. AVMs treated with volume-staged radiosurgery fell into 3 stereotypical cohorts. The great majority of the lesions were big, hemispheric AVM, which accounted for 24 of the initial 34 treatments. By token, another 5 AVMs each were either medium-sized lesions in deep, dangerous locations, or moderately large AVMs, for which it was felt that an increased margin dose was beneficial. Within this same 34-patient cohort, 53% obliterated following the initial volume stage treatment, while 6 patients were recommended for repeat radiosurgery and subsequently obliterated, resulting in an overall cure rate of 71%. Of particular note, only 2 adverse radiation events were observed, or 6% of the volume staged cohort, a remarkably improved incidence of treatment toxicity, particularly as compared to other strategies for treating large AVMs. Returning to the example of the 8-year-old boy, we see that his lesion, which had a radiosurgery-based AVM score of 4.35, was ultimately treated in 3 stages at a total treatment volume of 39.4 centimeters cubed. Now 4 years out from volume stage treatment, the patient remains neurologically intact, with a small volume of residual disease in the left caudate head, which we anticipate considering for retreatment after another 1 to 2 years of follow-up. Although volume staging is a reasonable treatment strategy for many large AVMs, these remain challenging and high-risk lesions for which even the most sophisticated radiosurgery techniques may still be fraught. In the next example case, a 14-year-old girl presented with right-sided weakness referable to a large diffuse AVM overlying an expansive region of eloquent left frontal cortex. The patient underwent volume stage radiosurgery in 3 treatments to a total treatment volume of 37.8 centimeters cubed. Although she did well initially, her clinical course was highly complicated. At 6 months after radiosurgery, she presented with worsening headaches, weakness, and partial seizures, which required management with corticosteroids and hyperbaric oxygen. At 30 months after treatment, the patient was noted to have a favorable response, which was encouragingly accompanied by improvements in her neurologic status and a successful steroid wean. Unfortunately, at 32 months, she suffered a catastrophic hemorrhage, which resulted in a dense hemiparesis and required operative intervention for clot evacuation and resection of residual disease. To date, the largest single-center experience with volume-stage stereotactic radiosurgery for large AVMs was reported by Nagy et al. In 2017, based on the patient cohort treated at Sheffield. In their series, 84 patients were treated from 2007 to 2013 with an overall obliteration rate of 61%, 7% adverse radiation events, and 4% mortality. Of particular interest, this very low incidence of treatment toxicity is quite encouraging and improves markedly on the preceding strategies of conventional radiosurgery, combined embolization, and temporal staging for these high-risk lesions. In summary, based on our experience in the preceding literature, we conclude that large volume AVMs can be safely managed using volume stage radiosurgery. Further study is needed on dose escalation and decreasing the treatment volume per stage to determine if this will increase the rate of obliteration with this technique. Finally, in consideration of the complexity of these lesions, AVM patients should be treated at centers with expertise in embolization, surgical resection, and radiosurgery. We hope that you have found this educational presentation on the treatment of large AVMs with radiosurgery educational, and thank you once again for your time and interest.